regards to proteomics type of studies. My question for you is this: does it matter where you get treated in terms of the ability of that clinic to select the right therapy? So in other words, pathology is widely available, proteomics may not be. Is that better, worse, or is it the difference?
Sure, and that's a great question. So one of Dr. McDermott's last slides, the one where he showed the different pathology, the different boxes showing the different patterns that you can see under the microscope, he put underneath each one of those some of the pathways that have been implicated as being important for those specific types of tumors. And that's to me really where we're heading with this, is that not only are we looking at the pattern of how things look to the eye under the microscope, but also looking at what pathways are amplified, what mutations can we find. And so I think that the short answer to your question about whether it matters where you're treated, the short answer is yes. But if you're being treated at any of the institutions represented here in Boston, represented here today, you're really going to be evaluated on those fronts in addition to just standard pathology. That sort of testing is not available everywhere. One of the things that I think is very important is a patient who lives, what often I encounter are patients who come in for a consultation trying to figure out what's the best therapy for them. But they live somewhere in Western Massachusetts, and it's a really long drive to get into Boston and to fight through traffic and to park and get all the way up to my clinic office where I can see them and talk things over. But patients like that aren't without options. It's very common. I think all of us here are very used to working with oncologists who are at other sites outside of Boston, such that the patient can come, meet one of us, get the fancier testing that's available here, but then also have a specialist like me work with their oncologist that's just up the street from where they live, so that as long as everybody's talking to one another, we can kind of benefit from the fancier testing, but also not be fighting through traffic quite so much. And it looks like Dr. Chueri has some thoughts on that.
Yeah, I want to add some things, especially about genetic testing of the tumor, because now, I mean, it's impossible to Google cancer gene, not finding something in a center that is offering, the next best thing in terms of genes. The issue and the danger sometimes of how to filter information, can be sometimes really problematic. And I'm going to tell you why in kidney cancer it's not much so applicable. We and others have sequenced, kidney cancer, tumors, and others, and there's a lot of mutations, and we really base ourselves on mutation, the things that can change the DNA and make the cancer, addicted to something. The issue is that there are a lot of genes, there's a lot of mutation, but you need to find in a disease the mutation that is druggable. And again, I want to emphasize the word druggable. It's from drug. I don't think it's part of any dictionary. Druggable. That means, for example, if you have a mutation like in RAF, in BRAF, or in the PI3 kinase domain, which are very rare in renal cell carcinoma, but for example, more common in something like melanoma, the BRAF mutation. Now we're learning 40–50% of melanoma have BRAF, and therefore we have drugs that target that. In kidney cancer, we have mutations. We have the VHL mutation, which is a hallmark of kidney cancer. But what does it mean? Is there an anti-VHL drug? There isn't. We know VHL increases VEGF. Does it mean if you have a mutation, you're more likely to respond to drugs that target the VEGF, like sunitinib? And we and others have done that work, and we found that there is no difference for whatever it matters. So yes, I think the era of genetics, for every cancer, it's going to come and be part of the standard of care. But each cancer is different in presenting or in having a druggable mutation. There is recently a newly described mutation by the Vintage group in the same region of VHL in 3P, in like 40% PBM. But what does that mean? How can you get a drug that functions and that works on that mutation? Is there a drug available? No. So what we do is that information, we put it on the shelf, waiting for something that works, around their genes. But it's not always a slam dunk. What we found in breast cancer, in the HER2 amplification, melanoma, and the BRAF mutation, so far it does not apply to kidney cancer.
So I agree with all of that entirely. And the thing that should be said in addition to that is that it's a moving target. So if we make a strong statement about what are the targets that we're able to home in on in clinical trials today, that statement may not be identical even a couple months from now, because all this is always in a state of flux. So going to someone like Dr. Choueiri, who spends a lot of time thinking about this, is something that it's hard to argue with.
But not always successful.
Yes, absolutely.
Okay, excellent job, Phil. One more question? Okay, I guess.
My question is twofold. One is, will these presentations be made available to the group electronically?
Well, yes and no. Last year, we put them all on our website and videotaped them. And they're pretty similar. So all of those are now available. If people were to ask individuals for their talks this year, we certainly would provide them. Just email us. I don't think, we don't have the funds to put them all up on the web this year.
Okay, I'd like a show of hands. I also had IL-2. I wanted to see how many people here are IL-2.
Okay, so Phil did an excellent job making complicated subjects easy to understand and just summarizing a ton of information in a very short period of time. And there'll be more time to ask these questions as you have them throughout the day, because I'm sure some of these issues will come up again. The last thing I would say about the genetic testing is one of the reasons we often come to you in clinic, many of the young folks in the back who you'll often meet, asking you to sign forms to donate your blood and old tumor specimens and sometimes urine specimens to the cause. It's just for that reason. It's to look for new targets, trying to develop new ways to find new vulnerabilities in these cancers. That's the reason we're trying to collect this stuff. So when someone approaches you with a consent form and says, can we have a piece of your tumor, that's the reason why. And we need to get more tumors, more tissue in our bank so we can make new discoveries. The next lecture is by Dr. Drew Wagner, who is our Director of Minimally Invasive Urologic Surgery at Bethesda Deaconess, and he's going to focus on focused treatments for kidney cancer in 2011. Thank you for coming.
Okay. Thanks, Dave. Thanks, everybody, for coming. Good morning. I just wanted to mention real quick, there is a typo in the handout on the schedule. It says that I'll be talking from 10 to 10:30. It's actually 10 to 12:30. So sit back, relax, get your coffee. And also, I hope there's some videos here of some fairly explicit surgical videos, different one than I showed last year. So if anyone gets queasy at the sight of robotic kidney surgery, you're going to have to leave. So, just kidding. So, here we go. And I'll be happy to answer any questions that everybody has at the end. So the objectives of today are to talk mostly about focal therapy. So this is a talk that is really centered on smaller kidney tumors and not necessarily metastatic disease, although we do a lot of work with surgical work on patients with metastases and cytoreductive nephrectomy. And one of the main points of the talk is to point out the fact that laparoscopy, or minimally invasive surgery, is really the approach of choice for most renal tumors, even very large or very advanced renal tumors. Partial nephrectomy should be the primary objective, whether it's done through open or laparoscopic surgery for almost all small tumors. We should at least aim for that. Laparoscopic or robotic partial nephrectomy is now common and safe in experienced hands. And percutaneous ablation, which a lot of people have probably heard about, has a limited role for small renal masses. So real quick, everybody, many people in this room know kidney cancer staging. Most of my talk is going to focus around stage 1 disease, which is relatively small tumors, 7 centimeters or less. As we know, stage 1 and 2 has a very high survival rate, up and over 90% for most patients, and that differs